Hello and welcome to Perspectives. I'm your host, Rondrick Williamson. Think back with me for just a moment to the year 1981. It was quite a significant year. The first test tube baby was born. Researchers found the wreckage of the Titanic. Sandra Day O'Connor was nominated to the United States Supreme Court. And AIDS, HIV, began to wreak havoc on men, women, and children. Now, when we began to talk about HIV and AIDS, several emotions began to surface: fear, anger, and resentment, just to name a few. Today, we're going to discuss the causes of HIV, some of the treatments, and try to raise awareness of the condition. Here with us today is Dr. Harold Kattner, who specializes in internal medicine and infectious diseases, and also Dr. Kattner has received a congressional commendation for his research with HIV and AIDS. Also, July 22nd, in the city of Macon has been called Harold Kattner Day. Along with Dr. Kattner is Vanetta Ferguson, who is a 20-year survivor of HIV/AIDS. Welcome to Perspectives. Thank you for being here on today.
Thank you.
Dr. Kattner, let's start out by let's talk about what is the HIV/AIDS virus?
The virus is what we call a retrovirus, and it's a group of viruses that we first discovered, or at least in humans, probably back in the 1970s. The first two viruses, one was associated with leukemia, the other one caused some other issues and sort of strange kind of conditions in humans. In 1981, of course, you talked about AIDS, and it wasn't until about 1983 that we discovered the virus that caused AIDS, which was also one of these retroviruses. And it's a virus that's very interesting because it works backwards. Like we have DNA that makes RNA that makes proteins. This is an RNA virus that makes a copy of itself as a DNA, and that DNA is then put into our DNA. It takes over the machinery of our cells and makes literally billions of baby viruses every day.
Right. So where did it come from?
Well, most people think it came out of Africa. I disagree with that. My research was the origin of AIDS when I was in my fellowship. And, you know, very classically, when people see a bad problem, they always blame it on somebody else. Like syphilis, for instance, was called a French disease in England, an English disease in France. And realizing that what we call ethnocentrism is a very common characteristic of all cultures. When I first started studying this back in '83, well, I studied it before I even dealt with patients back in '81, I sort of thought maybe this is a ethnocentric response. Maybe we're blaming it on Africa or Haiti or wherever, as most cultures would do if they found something like this. So my research looked for cases of what looked just like, to fit the definition of AIDS in the past, and I found a case that looked just like AIDS all the way back to the 1800s. And then I looked for changes in our culture if this disease was here that could have spread the virus. And of course, we had the sexual revolution back in the early 70s. And there was epidemics of syphilis and gonorrhea and herpes and all these sexually transmitted diseases. So I really think it's been here, endemic spread. If you only have one partner, you only give it to one person. But if you change your behavior, you can give it to thousands of people, hundreds and thousands of people. And people say, well, gee, Dr. Kattner, those epidemics occurred in the 1970s. Well, but remember what we're measuring in the early 80s is full-blown AIDS. Those people have been sick for 10 years, infected for 10 years. You take that curve, you back it up 10 years, it fits right on top of those other curves. The other reason I think it came out of Europe, Asia, Middle East, wherever, you know, not out of Africa, is because you've got a genetic resistance to this disease, and it's called the delta 32 CCR5 mutation. As you know, the CCR5 is the receptor on the cells. If you have a mutation of that receptor, the virus can't attach. So if you have two copies of that receptor in your body, you can have sex with all the people you want to have HIV, you can't get HIV. Every single disease we've ever seen on the face of this earth, over time it selects out a resistant population. So when you bring diseases that to a population never seen it before, they get sick. Like measles almost wiped off all the Hawaiians off the face of the earth because they've never seen measles. Smallpox are the same with American Indians. So HIV is sort of acting like a new disease in unexposed populations, i.e. Sub-Saharan Africa, African Americans, Haiti. And again, if it came out of those countries, those regions of the world, we should see the resistance in those populations, but it's not. It's in Europeans.
Because if you read the literature, most people tend to think that it was derived from a monkey, so to speak.
And it's very interesting because Jane Goodall back in the 1970s in a book called In the Shadow of Man, described chimpanzees stealing human babies and eating them. Now, chimpanzees don't cook and they don't use condoms.
Right.
So if that baby had the virus, did it really go from chimpanzee to man or man to chimpanzee? We have retroviruses in sheep, goats, cows, and horses that broke off from my virus 10,000 years ago. Those animals were domesticated in the Middle East, Europe, and in Asia, not in sub-Saharan Africa. How do those animals get those viruses? Well, I'll give you some theories on that. I wouldn't want to go into this on TV, but they're very, I mean, these viruses were cousins of our viruses, but they're not in sub-Saharan Africa. The virus in Africa appears to have broken off 40 years ago, maybe. And so again, did we introduce that virus into the African population? Did the African population then, the virus then go to the animals from the what I just described to you?
Right.
HIV-2, which is in Western Africa, there is a group of prostitutes that have resistance to that virus. And if you know anything about the culture of prostitution, often the children or the female children go into prostitution themselves. That virus looks like it broke off from our virus about 400 years ago. Well, who arrived in sub-Saharan Africa 400 years ago was the Portuguese. So again, is in that part of Africa, in fact. So again, did we bring this virus to Africa, or did Africa was a source of it? I'm not saying I'm right, but I just think we need to question this a little bit more. And I published on this. I published back in 1987 my paper before we even knew the genetic issues. And I looked basically at cases that fit that definition. In fact, another group of investigators published a paper a month after me, found the same thing. They looked for, I was looking for these malignancies. They were looking for opportunistic infections. And they found an additional, I found 30 cases, they found another 18 cases. In fact, one of their cases was out of St. Louis, Missouri. That guy died in 1968 of age-related illness. He had such a strange death, they put his tissues in a freezer, and they pulled the tissues out in 1986 or 87, and they looked for HIV. He was full of HIV. He died of AIDS in 1968 from St. Louis, not from sub-Saharan Africa, but from St. Louis. So again, was the disease here, and because it's most easily transmitted at the very beginning of the infection, at the very end, a man could be infected, not infect his wife till the very end of his disease, he dies of something, she's infected, she marries somebody else, doesn't infect her next husband till the end of her disease. So again, you can have a low level of infection in a population until changes in behavior.
Right.
The sexual revolution was the perfect mode of transmitting a virus like this.
So I guess the jury is still out on exactly where it came from.
In my opinion, it is. Most people, again, really, I mean, the vast majority of scientists in the world really think it's out of sub-Saharan Africa. You talk to some retrovirologists who work with animal retroviruses, they support what I'm saying.
Now, what about the idea, I think you probably heard of the polio vaccine having a play on?
Yeah, I mean, you have a lot of conspiracy theories that, you know, we invented this thing, you know. We're not that smart, believe me. This is not, we're giving ourselves too much credit.
Right.
This thing is, if anything is diabolical, this is diabolical. If you look at these retroviruses, you know, we have these, the way we transmit or develop proteins, of course, is with amino acids. So we have 3 codons that code for different amino acids. So when we read our DNA, if we start at the beginning of that DNA, we read all these different genes and we make different enzymes and stuff. If the enzyme comes down and goes to the second codon by mistake on our DNA, it just reads nonsense.
Right.
You need to read 3, 3, 3, 3. But if you go the wrong 3, there's nothing there.
Right.
This thing, if you start off on the first codon, it reads 1 set of genes. You start off with the second codon, it's got another set of genes. The third codon is another set of genes. So in 10,000 base pairs, it really is not a big, long DNA. It's very short, in fact. This thing packs all of its enzymes, all of its information that can produce a parasite, literally a virus that can eventually kill someone. And it's an amazing infection because it allows you to reproduce, only kills 1/4 of your progeny. So you have more victims for it to kill off in the future.
Right.
And again, it takes a long time to do so. So you have a chance to infect others in the process. So it's a very horrible disease. And and horrible virus, and the thing mutates. It mutates. My God, it's up to 9 mutations per replication.
Right.
So it's a mutation machine.
Right.
So we're always chasing it with these new antiretrovirals, and it's unbelievable when you think of what this thing can do. And it's so tiny, and the damage it does is just devastating.
So it's a retrovirus, and so kind of tell the viewers what's the difference between HIV and actually AIDS.
Well, since we didn't have a cause of this when I first started working on it, we didn't know what it was. We grouped all the conditions that are caused by the virus into what we call a syndrome. So in other words, some of them had pneumonia, some of them had cancers of the brain, parasites in the brain, tuberculosis all over their bodies, you name it. There's just a whole host of these different complications of AIDS. All of these things have one thing in common, and that is they represent, or they occur when there's a loss of this part of our body called the cellular immune system. The cellular immune system is that part of the body that the virus destroys. So again, all we could really describe before we had the virus was what it did, the end stages of the disease.
Right.
So that's what AIDS is. When HIV was discovered in 1983, and we probably saw there was definitely a connection with that virus by, I'd say, May of '84. Then we could look at the earlier stages. And so HIV is the virus, and it initially causes, in many people, an acute retroviral syndrome, which is a very severe, almost like mono or the flu. And they get better after that. And most of the time they stay better for 10, 15 years, sometimes 6, 7 years, sometimes less. And only with time does that virus slowly destroy that immune system to the point that once it reaches a critical nadir, then it allows all of these things that we have in our bodies to become disease, make us sick. So it's, again, AIDS is the very end stage of this infection with HIV.
So we're saying that it can present itself as common flu or common symptoms that we see, or we as physicians see on a daily basis. So is there anything that's pathognomonic to HIV/AIDS as opposed to any of the other disease entities that are out there?
Well, the acute retroviral syndrome is you have to have a high suspicion. So in other words, if someone walks in the emergency room, which often is where you pick it up, they may have a lot of lymphadenopathy. And most of the time it gets diagnosed as mononucleosis. Or just a really bad case of the flu. Often, though, they're sick for a couple of weeks, sometimes even hospitalized for this. So it really takes, and you can have rashes, but the rashes are very nonspecific. You can have lesions of the mouth, but again, nonspecific. And it'll drop your T cell count very early, transiently. But if that T cell drops to the point that you get so low, it could even cause an AIDS-defining illness early on.
Now, excuse me, for T cells, for the viewers who don't know what a T cell is, could you explain what a T cell is actually?
T cells is part of our immune system. So when you go to the doctor and you get a blood count, they'll give you, your white count will be like 5,000, for instance. You know, part of those are what they call neutrophils, which fight off bacterial infections, and part of them are lymphocytes. And the lymphocytes are involved with fighting off things like tuberculosis and cancers, these sorts of things. Of those lymphocytes, there's a lot of different components of these, and T cells are some of those lymphocytes, and T cells are what's destroyed by the virus.
So what happens next once a patient comes into your office, is diagnosed HIV positive? Is treatment based on the level of T cells?
Yeah. The lower the level of T cells, the higher risk of you getting sick. And 200 seems to be the cutoff. So anything below 200, you're at very high risk of getting AIDS. Now, it also depends on the function. So sometimes it can be higher, you still get sick because they're not working. But for the most part, we try to start therapy below T cells below 500. It used to be 350, but we found between 350 and 500, people died of not age-related issues, but other things. Because when your body's sitting there fighting this little thing, and it's creating all of these, what they call cytokines and other things in your body that, you know, increases your risk of cancer, increases your risk of heart disease. So we realized by waiting longer to treat, we're still losing patients,
right.
but not from AIDS, but from all the complications of their bodies fighting off this virus.
Right.
So now we use a CD4 count or T cell count of 500. Some people are recommending starting as soon as you see the patient, no matter what their T cells are. They could be 700 or 800. And that's great if you can afford the drugs. But it may be, and we may find out in the future that it may be important to start even earlier. But again, issue is the cost.
So I know that from the early 80s, the treatment has changed dramatically from the old AZT. So what are some of the new things that are on horizons? I know there's antiretrovirals out there. And I know some of those medications back in the day would cause other problems in the patients as well, make the patients even sicker. Is there anything new on the horizon as far as treatment?
Yeah, there's a lot of the newer HIV meds have, again, but they're new, so we don't know if they have long-term side effects. I don't know if you'll be speaking about what you've been through, but you'll see a lot of, I mean, the newer ones tend to be less toxic as far as causing, there's a difficult, complicated medical issues, but like they can cause acidosis in patients, the older ones can, and they can cause changes in the body, fat levels, and they can, I mean, some of them precipitated diabetes. I mean, it was just horrible stuff. The newer ones have less of those side effects, and of course we're studying them and we're looking for those side effects early on. Some really fascinating stuff is some of the stuff they're looking at experimentally for possible cures, and that's very exciting. Go ahead.
Yeah, I wanted to ask about that. I read something about the Berlin patient, and it was interesting to me because this was a gentleman who was HIV positive, and I think also had leukemia as well.
Right.
And they tried this therapy on him, and actually now he's HIV free.
Yeah. Well, we talked about early origin of AIDS, and this Delta 32, this mutation on the receptors of our cells. Again, if we have 2 copies of this receptor, the vast majority of the viruses out there can't attach to your cells. So what they did when this guy had leukemia, he needed a bone marrow transplant. So they found a donor that had 2 copies of this mutation that prevents you from getting HIV. So they took and wiped out his bone marrow, treated his leukemia, and they gave him a bone marrow of a person that's resistant to HIV. And then they measured the virus in him. They took him off all of his HIV meds. And to this day, he's been 3 or 4 years out now, there's no evidence of any virus in his body.
Right.
So we believe he's cured. Now, it's a great model and it works, but bone marrow transplants are very dangerous and extremely costly, about $1 million. And the cost of, and the physical cost of a bone marrow transplant is enormous. I mean, the death rate is high just in the bone marrow transplant. So it's a great concept. And they're looking at ways of maybe introducing through gene therapy some of these things, and that'll be fascinating.
Yeah.
But they're also looking at a gene now that can turn the virus off. And if they can insert segments, this turn-off gene inside of the host who's got the virus, then maybe we'll just shut it down, just what the medicines do. I mean, the medicines basically shut the production of the virus down. There's also things in works right now where once your virus is quiet after you take your medicines, the cells that the virus lives in will all die off after about 70 years. And, so I tell my patients you're on a slow cure. But some of them it'll be 90 or so before they get cured. So but if you could find a way to expose those cells, then the remaining T cells could destroy those memory cells. And so they're looking at compounds right now that can maybe express that DNA on the surface of the cell, maybe not making too many copies of the virus, but at least showing on the surface that this virus has a bad problem.
Right.
And the T cells themselves can destroy it. And there's been some papers on this, and they've shown a marked depletion of these cells. So that might take 4 or 5 years. We don't know.
Right.
That's what they're looking at right now.
But isn't it possible for the HIV virus itself to hide, so to speak, and be undetectable in a patient? I think I read somewhere where the virus can lie dormant and won't avail itself until...
Yeah, well, when you put them on the medicines, you've got, you put it to sleep. I mean, you shut it down completely. So I just came from my clinic, and so everybody I saw today, They had less than 20 copies that they could measure in the body. So all their medicines are, if they take it perfectly, there's not a single virus that you can find in the bloodstream. It's there, the DNA is there, so as soon as those medicines are taken off, then that virus just goes wild, expresses itself. So there's a dormancy in that sense.
Right. There's a couple questions I want to ask. Back in 1981, I think it was, when Magic Johnson was diagnosed. It's been 20 some odd years now, and what I hear is that he's HIV free.
I've met him 3 times.
And actually, they were talking about him this morning on the CBS Early Show.
Really?
Yeah.
He's very honest about this, and he says he takes his medicines every day. So his virus is suppressed. There is no virus in his bloodstream. But you know, if he stops his medications, that virus will come back out again. Now, right. As I said, I've met him 3 times, and that was one of the issues the physicians had, that these kind of rumors are out there. So people would just say, well, gee, if Magic Johnson's cured and I'm undetectable, maybe I can just stop my medicines. But he's not cured, and he'll say he's not cured. And he was very fortunate because he was able to get on some of these protease inhibitors at a very early stage, because they were still, I think he got on some of the trials, if I'm not mistaken. I don't know all the details. But he had Dr. Ho as one of his doctors, who was one of the world's experts in this.
Right, and actually Dr. Ho was on the show this morning as well.
Oh, really?
Yeah,
okay.
Yeah. So let's dispel some myths out there, because I know people think, when you hear HIV/AIDS, they think the sky is going to fall out. I can't touch you. I can't use the same spoon you've used. I can't drink out the same mug that you just had. I can't wipe your tears. I can't kiss you, or what have you. And what I've looked at myself is that those are just myths.
Well, they are. I mean, if anybody would have gotten it, it would have been me. I'm coughed on, sneezed on, cried on every day of my life by people with HIV. And I've been doing this since 1983. And I get my blood tested just so I can tell people I don't have the virus. In fact, I drank after an AIDS patient 500 times. There was a guy in my church, where I'm Catholic, and we all drink out of the same cup every Sunday. And this guy, for 10 years, I sang in the choir with him. He'd drink first, I'd drink right after him. And only after 10 years did he come down with full-blown AIDS. And so I knew ever since I was drinking after him, he had full-blown AIDS. Or HIV. So there's just no evidence of transmission in that manner. And you know, mosquitoes, they fed the virus to mosquitoes, and they were surviving the mosquitoes. And believe me, I go to a lot of picnics with my patients, and I probably eat at every restaurant in town. The reason I'm so fat, because my patients work there and they always give me extra food. So you just can't, you just can't get it like that.
Wow. So what are some ways you would, tell the viewers on how to protect themselves from getting HIV/AIDS infection or HIV infection?
Well, if you look at the condom studies and the good condom studies, like in Italy, where they teach people how to use them, there was no transmission. And they looked at 15,000 episodes of intercourse between discordant couples. One person had it, the other one didn't. So condoms are definitely safe. And if people use them correctly, the risk is really 0. If a person is married to someone with HIV and that person takes the HIV person takes medications, that viral load is extremely low. The transmission rate, again, is almost 0 if the person who's taking the medicines is undetectable at less than 1,000 copies, let's say, and most of them get down to less than 20. I mean, other than, it's a sexually transmitted disease, bottom line, and it's, how do you, it's based on trust, it's based on everything else, but obviously I'm quite busy. We're diagnosing about a new case every 3 days, this community, and most of the people don't know they're passing it, but there are some that do, and that's where it really gets tragic.
Well, let me ask this question. When HIV/AIDS first surfaced, it surfaced as a disease of the homosexual population. Was that just something that occurred, and because it occurred in those few men, that trend carried on throughout the years? But are we still seeing that as a trend, or that's beginning to drop off?
Well, you're still seeing it there, but you're seeing more females too. And it's interesting. There are certain types of intercourse that really put you at higher risk. Like anal intercourse, I mean, the penis causing trauma to the anal area, the virus, when it ejaculates inside the rectum, the virus can attach to the cells in the rectum very easily. So it's the efficiency of transmission. Oral sex, I mean, it's risk. It has some risk, but it's very, very low. That's why if you see lesbians that are discordant couples, I mean, the risk of transmission between two females is almost zero, if not zero.
Right.
Regular vaginal intercourse, the risk is mostly to the woman. If a man is circumcised, has no lesions on his penis, no herpes, no syphilis, no genital warts, his risk of getting it from that woman is really, really low. I mean, some studies say 2%. It might even be less than that. So it depends on the form of intercourse. So if two men are having anal receptive intercourse or active anal receptive intercourse, one's positive, well, his risk of transmitting to that other person is very, very high. If two gay men are homosexual men are having oral sex all the time and they're positive, or one's positive, the risk of transmission is extremely low. And I've had many, many couples like that where that's all they were engaging in. One was positive, one was negative. The negative one couldn't figure out why he wasn't getting it because he was the receptive person, but only orally, not anally.
Right.
So it's a mechanical thing, and if the person and the receiver is the one that's at highest risk, whether that be a vagina or anus, and so but again, the mouth is less so.
Are you overwhelmed with vitamins? Do you have so many supplements that you have actually forgotten why you take some of them? Are you not getting the results you want from your new supplement program? Hi, at Scott's Pharmacy, we are extensively trained in vitamins, minerals, and herbal products. We are also experts at medications, various disease states, and drug-nutrient interactions. So no matter what your issues, blood pressure, diabetes to hair loss, we can help. Stop by Scott's Pharmacy for a consultation and start looking better, feeling better, and being better.
It's important to get tested and to know your status. Continue to watch us. Continue to tune in every week. Again, you've been watching Perspectives, where you're not only informed but inspired. Listen, if you're a Facebooker or a Twitterer, follow me on Facebook and on Twitter. You feel free to visit my website, perspectivestv.com. Listen, on December 5th, we'll be taping 2 wonderful episodes, so we want you to be in the audience of that show. To be in the audience, just go to my website, perspectivestv.com, and click the Be on the Show link. We'll see you next week.